Alrighty, well, today I'm talking about hysterectomies and the options to hysterectomies. Now, at least looking over who we've got here today, that probably isn't a thing that's top on your mind right now. But there's different problems that happen with women throughout the years that can lend themselves to surgical or medical management with bleeding. Before we get into that, with Dr. Allred, he introduced his family. This is the Evans family, et al. And this is my wife, Esther. This is over in Jackson Hole. These are our 3 boys. We have 9 kids. We lost 2 during the education process. They passed away, and these are the remaining. These are the grandkids, and as I've mentioned to a number of people, that had I known that grandkids were going to be as fun as they are, I would have skipped the first half in a heartbeat. This is my son and daughter-in-law, and my daughter-in-law, or my daughter and son-in-law, and this is on vacation last year with 2 of my daughters and my wife and I. This is one of my grandsons. It's a pistol, and another daughter-in-law and son, and this is my son and his wife, and another daughter and her husband, and they're all spread out, and nobody knows how to do anything except medicine. Everybody's either in med school or in their residency or in dental school, and anyway, so that's the Evans family. Let's move on. What is the best procedure for me? As life goes on, that question comes up, and I've seen, and as practitioners, we see where women will go through life and having problems with their periods and whatnot, and finally get to the point of say, you know what, I'm done with this. I'm ready for this to go away, and I want something done, either permanently or semi-permanently. When we talk about treatments for abnormal bleeding or other problems, the first thing that usually comes to mind by everybody is hysterectomy, which is by definition a removal of the uterus. There are several different ways of doing this. One is abdominally, where we open the abdomen up. Vaginally, laparoscopically assisted vaginal hysterectomy, where we put ports or little incisions in the abdomen, and we're able to manipulate and do surgery without having to open you up. And then a laparoscopic hysterectomy. Other things that we're able to do are endometrial ablation, which is destroying the inside of the endometrial lining. And this is a vaginal approach. We're able to do this either in the office or at the hospital. And then pelvic reconstruction, which is either a vaginal approach or an abdominal approach. Again, when I talk about abdominal approach, I'm talking about a large incision. Let me give you an example first. We've got to go through some basic anatomy so that we all know what we're talking about right off the bat. First of all, a total hysterectomy is removal of just the uterus, okay? A hysterectomy plus a big word here, bilateral salpingo oophorectomy, which is a big word for saying we're removing the ovarian tubes. Removing the ovarian tubes right here, and then finally a subtotal hysterectomy is where we leave the cervix intact, but we remove the uterus itself. Now, why are hysterectomies done? First of all, usually uterine fibroids is one of the big things. Uterine fibroids are a benign or non-cancerous type tumor that grows in the uterus. In the African American population, about 50% of women have fibroids. In the Caucasian American population, it's about 25%, and they can wreak havoc with irregular bleeding, feeling pressure, pain, and so on. Endometriosis is another indication for it, or for a hysterectomy. It is when tissue from inside the uterus grows on the outside of the uterus. Either behind the uterus or on the ovaries. And what happens when a woman goes through her period, excuse me, when she goes through her period, you'll have bleeding, just like normal bleeding that you'll get vaginally, but you have bleeding going on in the abdomen itself. Now, I don't care whether you're a boy or a girl, the bottom line is when blood is in the abdomen and it's not supposed to be there, it hurts, and it hurts big time. And that's why a lot of women have so much pain with endometriosis. Pelvic support problems, I'm falling out. Now, there are women that go on, and about 10 to 15% of women will have this, where at the end of childbearing, or as the years go on, there will be essentially a falling out. And I'll talk more about that in just a few minutes. Abnormal uterine bleeding, where they bleed heavily. 1 day or 2 days out of the month, they can't leave the house because they're bleeding so hard. And you'd be surprised how many women will say, well, I thought that was normal. I just kind of planned on 1 day a month. I wasn't going to be able to take care of anything. Cancer is another indication for hysterectomy. And then chronic pelvic pain, painful periods, pain with intercourse, or pain with bowel movements. Now here again, this is reiterating what I mentioned earlier, the types of hysterectomies that there are. There's the abdominal approach, which is a traditional approach. We were all taught that in our residency programs on how to do that. And this is where we put an incision in the lower abdomen, and we go in and mechanically tie off and get and cut and get the uterus out of there. Laparoscopically assisted vaginal hysterectomies. This is an example of that, where we use those small ports in the abdomen. We go through the belly button and usually 2 other small ports that allow us to go in there, and then we watch on the video screen doing the procedure. And this has absolutely revolutionized surgery, not only in obstetrics and gynecology, but in all areas of surgery. We have a laparoscopically assisted vaginal hysterectomy, and we have a laparoscopic hysterectomy, and I'll get into the differences on this in just a few minutes. Vaginal hysterectomy is where we go in from the vagina, and we don't do any incision here or with the small ports. There are some concerns about that, but like I said, we'll talk about that in a minute. Okay.
In collaboration with Business Week magazine, CBS News has been investigating advances in surgery. One involves an operation that 1/3 of women have by the time they're 60. It can lead to weeks of painful recovery, but it turns out that kind of discomfort and recuperation time can be significantly reduced. As Dr. John LaPook reports in tonight's Eye on Your Health. We're going to look at her anatomy first.
Dr. Lori Warren is a surgeon who has a startling diagnosis for women.
I am on a mission.
She thinks hundreds of thousands of them are getting the wrong operation every year.
I'm outraged that doctors are still, in my mind, doing these archaic surgeries on people or opening them up unnecessarily. We're just going to right now just kind of look around.
The surgery she's upset about may be archaic, but it's very common. Hysterectomy is the surgical removal of the uterus. About 600,000 are done every year in this country. Most are recommended because of pain and bleeding from fibroids.
If patients really know that they have options when it comes to hysterectomy, that we'll start seeing some of the changes that I feel need to happen.
What's happening now is that the vast majority are done the old-fashioned way, with a large surgical incision and a 6 to 8 week recovery.
I just think that we need to open less people up.
Dr. Warren is one of relatively few surgeons who perform hysterectomy with a minimally invasive laparoscopic technique. Like all laparoscopic procedures, a camera is inserted through a tiny incision to see into the abdomen. 2 other small incisions are made so that tools can be inserted.
Can dissect here like that.
It's all over in about an hour, and patients are usually home within a day and back to normal within a week or 2.
Interesting.
Does it still amaze you after all these years?
Oh yeah, I'm amazed by what we can do, and what's most amazing to me is how well the patient does.
Becky Rupert just had a hysterectomy, literally. Now, she wants to go home.
So about 5 hours ago you had your uterus out, and how do you feel now?
I feel great.
And the amount of pain?
I have no pain, literally no pain.
I'm really thinking about this all the time.
What frustrates Dr. Warren is that only about 15% of hysterectomies are done this way.
You would think in today's age and the way that we've improved in so many other areas in medicine, that women would begin questioning this, but we're finding that they're not.
So that's exactly where you want to be.
About 90% of all gallbladder surgeries are done laparoscopically. So why not hysterectomy?
Women are not seeking second opinions. They're going to the gynecologists that deliver their babies. They have that trust in them.
It makes my blood boil. It does. And that's what fires my passion to get the word out. So I never put a trocar in blind.
And to get the word out, she invites doctors to come to Baptist Hospital East in Louisville and learn the procedure.
What would you want for your wife, or your mom, or your sister, or your best friend? You would want them to have the least invasive procedure possible.
This surgery is not only easier on patients, it saves the healthcare system money too, Katie.
Is that because patients have to spend less time in the hospital? I can't believe that. One patient said,
amazing.
I have no pain, right?
Right?
And they get back to work sooner as well. So if this is so great, John, why are so many doctors still doing it the old-fashioned way?
Katie, I think one big reason is inertia. I remember about 15 years ago when gallbladders first started being removed this new way. It didn't catch on right away. What ultimately drove it to become the standard of care that it is now is patients coming in saying, I hear there's a new way of doing this operation where I can be back to work in a day or two. Ultimately, I think that's what's going to have to happen with hysterectomy.
So hopefully more women will demand this of their doctor.
Absolutely.
John LaPook. John, thanks so much. By the way, if you'd like more about this, you can ask Dr. LaPook. You can go to cbsnews.com and click on CBS Evening News. Send him your questions on non-invasive surgery, and you'll find his answers tomorrow online.
You may or may not have heard within the last couple of days, there was a release from the FDA having to do with laparoscopic hysterectomies. Has anybody heard about this? Okay, I'm going to do a preemptive strike here. At Harvard, one of the neurosurgeons at Harvard, whose wife had a laparoscopic hysterectomy, she's also a physician, they did the hysterectomy and it ended up being that it was cancer. And it was what's called a leiomyosarcoma, which is a very rare cancer, but nonetheless, it's significant. 30% of the time, prior to hysterectomies, we're able to do a biopsy and determine whether that leiomyosarcoma is abnormal or not. I mean, if the pathology in the uterus is abnormal or not, and it'll show up. That means there is some that we're not able to know before we actually go to the operating room, that we find out at the time of the surgery that it's actually cancer. Now, this neurosurgeon decided that he was, remember Dr. Allred's talk earlier about somebody having an agenda. The neurosurgeon went on this crusade thinking that laparoscopic hysterectomies ought to be done away with, that they're dangerous, all they're going to do is shower cancer throughout the abdomen, and really made a big stir over this. To the point that the FDA made this comment on April 17th that discourages the use of laparoscopically powered morcellation. That's how we get the uterus out of there. It's a spinning blade that takes the, you saw it on the video, but you probably didn't notice it. It's how we get the uterus through the belly button. Anyway, morcellation for the removal of the uterus or uterine fibroids. It poses a risk of spreading unsuspected cancerous tissue, notably uterine sarcomas, beyond the uterus. In other words, there are little pieces that we have to pick up afterwards and we take them out. Now, the interesting thing about what the FDA said was that there are a number of additional treatment options are available for women with symptomatic fibroid uterus. And they go through the different surgical things, and then they say down here, non-surgical options. Well, wait a second, can we stop the boat a second? If we're doing surgery and we find out she has cancer, but we didn't know that before, but it's okay to go ahead and leave the cancer in the patient. You follow what I'm saying? That doesn't make sense, okay? Then the next thing the FDA does, which I thought was very interesting, is that they said, based on the analysis of currently available data, the FDA has determined that approximately 1 in 350 women who are undergoing hysterectomy or myomectomy for fibroids have unsuspected type of uterine cancer called uterine sarcoma. So what that translates into is a 0.28%, meaning 1 in 350, that this is going to show up. It's less than 1% of the population that we deal with. Now, remember I mentioned earlier that 30% of the time you can do a biopsy and you'll pick up the leiomyosarcoma. So consequently, we wouldn't do that type of approach going after that. So stick with me here. So the effective rate of risk of picking up an undiagnosed cancer in there and spreading it is 0.17%. Okay? What's the risk of dying from a hysterectomy? 0.18%. Okay? Mark Twain once said there's lies, there's damn lies, and then there's statistics. And I think this is a very good example of that. That the FDA, this even gets better. ACOG, which is the American Congress of Obstetrics and Gynecologists, or Obstetricians and Gynecologists, said it's important for each patient to talk to the doctor fully about the risks and benefits of all procedures in surgical settings. Let's go to the next one. And then what's even more is the FDA, this is the area or the arm of ACOG that does all the laparoscopic surgery. They said we have yet to be contacted by it. The FDA went ahead and did this. The guy wasn't even an OB that put out this alert and essentially said this needs to stop. So what's happened in Boston, this was in the Wall Street Journal just this past week. What happened in Boston is the vice chair of the department said, okay, we're not doing any more laparoscopic hysterectomies. I mean, just a total knee-jerk response before anybody really stopped and ran the numbers. Now, if there's a way that we can avoid this, and there is some, we will probably be doing it in a baggie just because of this. In other words, not having anything showered in the abdomen to begin with. But I think, as you all can see, the overall risks are very, very low. And I go back to what Mark Twain said, and then there's statistics. And this is an example of that. Benefits of minimally invasive surgery are well known and include decreases in numerous highly morbid and postoperative complications, including deep vein thrombosis, pulmonary embolus. Deep vein thrombosis is a blood clot in the leg, and the one that you can have break loose and it can go to your lungs. If it goes to your lungs, there's an 80% mortality rate. And that's what is called a pulmonary embolism. Infection, sepsis, fascial dehiscence, which is the tissue that holds our abdomen together, and then bowel obstruction. Now, the interesting thing about this is about 3 months ago, I did a procedure on a gal that was very, very heavy. Hands down, this was the best procedure to go, as opposed to opening her up and putting her at much greater risk for all of this. So, bottom line is talk to your doctor about this if you're in that situation. At Madison Women's Clinic, for the last 5 years, 90 to 95% of our hysterectomies are done laparoscopically, whether it's a laparoscopically assisted vaginal hysterectomy or a laparoscopic hysterectomy altogether. Greater than 90% go home the next day, 1 to 2 week recovery, as was mentioned in the video. It does decrease healthcare costs, not only for the patient, but also for the whole system. Decreased time away from work and family. Usually when we do laparoscopic hysterectomies, women can go back to work in about 5 to 7 days. Now, vaginal hysterectomy compared with abdominal hysterectomy, it's a shorter hospital stay, faster return to normal activity, and fewer infections. Now, vaginal hysterectomy compared with laparoscopic hysterectomy, one of the big things is that, if you guys can just bear with me a second, if we're doing a vaginal hysterectomy, you don't get a good look at what's going on inside the abdomen, okay? So when we're putting in a scope up here, we're able to look inside and see what's going on. And it helps with undiagnosed things. We get to look at the whole abdomen, we look at the liver, we look at the gallbladder. Laparoscopic hysterectomy compared with abdominal hysterectomy, faster return to normal activity, shorter hospital stay, definitely less blood loss. We have, oh man, probably routinely about 1/3 the blood loss we have with doing an abdominal hysterectomy. Fewer infections because the incision's smaller. It's not going to get infected unless, if you got a big gaping hole versus a small hole, same as less operating time. When we do laparoscopic hysterectomies, I usually counsel women that it takes us anywhere from about 50 minutes to an hour and a half, and it depends on what we run into when we get in there. If there's scar tissue formation or whatnot, then it's going to take us a little longer. If it's just essentially a normal small uterus and we're doing it for abnormal bleeding, it takes us about 45 minutes to an hour to get that done from the time she's rolling into the operating room to the time she's rolling out. One difference that Dr. Allred and myself don't do, we don't send them home the same day. Now, it's not because we don't know how to do that. We just figure you're going through some awfully big vessels, and it's probably okay if they spend the night. As one of my attendings once said, he said, you can do it, but why? And we could send them home, but I think it's reasonable to keep an eye on them close by. And that's what we've chose to do. It's not because we're right and the other guys are wrong, it's just that we feel a little more comfortable keeping those gals close to the mothership before we turn them loose. Okay, options to hysterectomy. In a select population, there are those that an endometrial ablation would work very well for. It destroys a thin layer of the lining of the uterus and stops the menstrual flow in women. Now, there are several different types of endometrial ablations. When I was in Atlanta, we did the balloon ablation. We really didn't like it that much. It didn't work as well. There's a balloon, this is the uterus right here, and it goes up through the vagina and through the cervix, and it fills up with hot water in a balloon type fashion. It just kind of boils the inside of the endometrial lining. This is a cryoablation. I've had virtually no experience with this. Everything I've read, that's the reason I don't have any experience with it. It just doesn't seem to work quite as well. The NovaSure is a radio frequency. Now this is a fan inside, this is a metal type fan that opens up inside the uterus, and it essentially cauterizes the inside of the endometrial lining right here. And then lastly, the one we do the most of in the office is a hydrothermal ablation. And hands down, 5 years ago when I moved here, we'd had a little bit of exposure to that out in Atlanta. But when I moved here, these guys were doing this here, and I saw the first one. I thought, hands down, that's better than anything I've seen. And it works very, very well. Now, why is an endometrial ablation done? Usually for heavy abnormal bleeding at the time of the period. Usually we don't do it for women that are bleeding throughout the month. It's women that say, for 3 days out of the month, I have a tampon and a pad on, I can't go anywhere, and then it stops, and I'm fine the rest of the month. And obviously it's for those that have completed childbearing, and those that have, in which medical management, in other words, birth control pills, have not worked. Okay, who should not have an endometrial ablation? Those that have disorders of the endometrium. For instance, if you've had repeated C-sections and your lower uterine segment, where we go through to get the baby out, has thinned out, then it's probably not wise that we go ahead and do an endometrial ablation there. Endometrial hyperplasia or precancerous cells inside the uterus, that's an absolute contraindication to not doing an endometrial ablation. Cancer of the uterus, this isn't going to go up there and kill the cancer cells, okay? No, we need to get the whole uterus out when that happens. Recent pregnancy is another reason. Usually we wait anywhere from 6 to 12 weeks afterwards before we consider that. Indications by American Congress of Obstetricians and Gynecologists is when women have perceived heavy bleeding, and that can be different for any woman, to be able to go ahead and have an endometrial ablation done. And then of course infection in the uterus, you don't want to go up there and cauterize an infection. We want to get that taken care of first. Again, those are the options. Now, yeah, thank you. Okay, now, pregnancy after endometrial ablation? Absolutely not. Okay, does it happen? Yeah, and there's a report in the literature. That's why we feel very strongly that sterilization needs to occur, usually preferably with the female, okay? Because there are situations, and there's been reports in the literature, where husband and wife either split up or the husband passes away and he'd had a vasectomy, she gets remarried and her new husband hasn't had a vasectomy, and all of a sudden they get get pregnant. Oral contraceptives is also an option, but the one that both Dr. Allred and I feel very strongly about is female contraception. But talk to your doctor about it if that's where you need, or what you want to do. Advantages to endometrial ablation is a day surgery procedure. We do it in the office. It's done under local anesthetic. Now, when we say local anesthetic, there's just a little more to it. It's a regional type thing that we did in the whole uterus. And it's not like, you know, we get just a little bit like we're taking mole off and the rest of it hurts. We get you good and numbed up, and women do very, very well with this in the office. And then it's a rapid recovery. Essentially, a lot of women go back to work the next day. Okay, let's talk about pelvic reconstruction. It's done to relieve the symptoms of I'm falling out, to relieve symptoms of urinary retention, which when women are falling out, what can happen is it can kink off the bladder, and so it's difficult for them to urinate, and the bladder just fills up more and more and more, and they essentially retain that urine. It's to relieve symptoms of constipation and to relieve symptoms of stress urinary incontinence. Now, let's do a quick anatomy lesson here. This is a normal cross-section of a female pelvis. This is the rectum coming down here. This is the uterus right here and the vagina. This is the bladder, and this is the pubic bone. In somebody that has a rectocele and a cystocele, which are big words for my rectum poofs out into my vagina, or my bladder poofs out into my vagina, okay? So in this situation, in the rectocele, which is the rectum poofing out, this comes from having delivered babies. The most common cause of this is when you hear people say, well, the baby was coming posterior, or it was sunny side up. This is what causes most of the problems of support in that back vaginal wall. The cystocele usually is associated just with big babies, and then also weak tissue in the area. Androcele is a situation where the bowel comes down into this tissue that's between the vagina and the rectum, and it comes down between the vagina, which is right here, and the rectum. And then lastly, this is a uterine prolapse, where the uterus just comes out. Now, you may or may not have seen this before, but we have women that come to us, usually in their 60s and late 50s and 60s, even up to 70 and 80, that come to us with their uterus coming out this far, and it is a big issue. Okay, what are the causes? Having kids, prior pelvic surgery, menopause, aging, intense physical activity. I remember this one gal that I took care of back east that, let me tell you, I mean, she'd had one kid, but she was like a longshoreman. And she would lift 50-pound bags of whatever the material was. I mean, she threw them, yeah, I mean, I want to say potatoes, but it wasn't potatoes back there. And that is what had taken the toll over time. Genetic predisposition. Most of the time, it's something that we're dealing with the tissue in a woman's body on being able to or when they have this problem, and then of course when it comes to trying to fix it, we're still dealing with that tissue. And then chronically increased abdominal pressure, obesity, constipation, chronic cough are also things. Women that have asthma or smokers have that problem. Now treatment, the non-surgical approach is lifestyle changes, decreased fluid intake if you're losing urine, fiber and laxatives to help with the moving the stool through, bladder training, time voiding type stuff, and then weight loss, as well as pelvic floor exercises, which a lot of times are called Kegel exercises. Now, as far as Kegel exercises, women after having given birth, we're aggressive with talking to women about this, primarily because it helps to tone up the pelvic floor again afterwards. And there are many different ways of doing that. I'll talk about that later on. But one of the best ways is to go in and sit down on the toilet, start urinating, stop, start, stop. Find out what muscles you need to control the flow of urine, and then every hour you're awake, 10 times an hour, you practice. You don't need to be on the toilet to do this. You don't need to actually be urinating to do this. You practice tightening up, count to 5, and release. Tightening up, count to 5, and release. And that can help get tone back into the pelvic floor and help a problem with urinary incontinence virtually become no problem at all. About 50% of the time when people come to see Dr. Allred and myself and see the nurse practitioners about urinary incontinence, 50% of the time we don't need to do surgery on them. It's just a matter of tightening up that pelvic diaphragm is what we call it, and tightening up those muscles. And then, can't go back there. Then a pessary is where we put different types of support up in the vagina itself. Usually we use pessaries in the population of women that are not good surgical candidates. In other words, if they're 85 years old and they're in poor medical health, we don't really want to take them to the operating room to hurry along the inevitable. It might be better if we just let them use a pessary, and we have a handful of women that come in and we clean their pessaries and put them back in for them because they're old enough that they just can't do it on their own. Now, treatment of pelvic organ prolapse, the other option is surgical. We have the abdominal approach, which is a traditional approach in which I spent a lot of time in Atlanta learning how to do, or in the program there. And then using which we use permanent sutures, the success rate is about 80% in the abdominal approach. Now, what we're looking at right here is a pelvis. If you are looking in through here, we've done an incision and you're standing right here and you're looking down at the pelvis, what we do is we go in and get the tissue from, this is the bladder right here and the vagina is underneath the bladder, and we reattach it back up and lifts that bladder back to where it's supposed to be. Other approaches are a vaginal approach. Unfortunately, back 20 years ago when I finished my residency, we were very heavy into pelvic reconstruction. And that's where I got most of my initiation and interest in that. But after about 2 or 3 years in the military, and we were doing these procedures and it was great and things were working out very well, the problem was the success rate just wasn't as good. And I know in my own personal practice, if you view every problem as a nail and the only tool you have to work with is a hammer, you know what happens. The same thing here, and that's why I went back and I spent that extra year learning how to do the more advanced surgery to be able to support this. Unfortunately, the more advanced surgery is a longer recovery because you have to open people up. Now, about 12, 15 years ago, they came out with a mesh approach. Now, how many people have been at the gym and heard Bangle, Bangle, and Bangle talk about using mesh? Have you guys heard about it? If you've had mesh, contact us right away because you may be entitled to compensation. Have you guys heard that? Yeah, we've all heard it. It's like, are you serious? Well, one of the problems with the mesh is that the companies that got into it, I delayed using mesh for about 7 years because I wasn't going to let my patients be beta sites, so to speak. Well, what happened was that a lot of the vendors and the companies that make mesh thought, well, we'll just put on these weekend seminars and have the doctors come and they can go and they can put mesh in, and that'll fix everything. You know, it'll be great. It'll be a great marketing tool. Well, I spent about an extra year going through advanced pelvic surgery, and I went to several of these meetings and hands-on clinic before I ever attempted my first one. And the reason being is the dissection is completely different than what we were taught in residency program. So consequently, you have the vendors trying to sell it to the OBs saying you can learn how to do this in a weekend, which you can't. I mean, that's all there is to it. And then What's more is that OBs that had no business putting them in were putting them in. Peggy Norton, who's at the University of Utah, absolutely detests mesh. And she's one of the best urogynecologists in the country. And she's a good friend, and we've talked about this at length. We do realize that there are some places where mesh are indicated, and the problem was that for the most part, where problems came from were the wrong people were putting them in. Now, both Dr. Allred and I have had extensive training in the mesh. We know how to use it, but again, we don't use mesh on everybody. And frankly, that we would leave to discuss with your physician when we get there on whether it'd be indicated to do that or whether we can use one of the other ones and use the mesh as a follow-up. And I think that's pretty much where we're ending up right now. Okay, and the FDA mentioned this again. You probably see all these disclaimers going on, but we need to understand what's going on. We'd much rather have you guys aware of this so you can make an informed decision at the time of surgery. One of the things that the FDA said is obtain specialized training for each mesh placement technique and be aware of its risk. And we have. And anything that Dr. Allred or myself would suggest in that setting is because we've been extensively trained. We're not saying that we need to do mesh on everybody. Far from that. Matter of fact, probably about a quarter of the people that we do, we use mesh. But nonetheless, that's what the state of the art is. Any questions? You're probably bored stiff with this right now. Anyway, hopefully one thing I've always felt very strongly about, being forewarned is forearmed. As you see this stuff, we do not cookie cut out the approach to patients. And each patient will have different needs and whatnot. And that's why Dr. Allred and myself feel so strongly about talking and saying this is the approach that I feel might be best for you. And anyway, yeah.
I'm totally okay. For myself, would an ablation or anything like that be a good choice for me? You know how I've had a tough time with my pregnancy with the bleeding and everything, and then I had my little girl 3 months early.
Only 3 months early?
It was 3 months early. Yeah, I know. She was 27 weeks exactly, so.
Doing the endometrial ablations, typically the recommendation is the heavy periods that come once a month.
Okay, so not necessarily.
Yeah, not necessarily intramenstrual bleeding per se. And part of this whole workup, whether the nurse practitioners, whether Rochelle and Becky have worked through the medical end of things, which a lot of the times if you've been seeing them, they have, and by the time you get to Dr. Allred or myself, we're talking about surgical management. And consequently, those things have been answered up until that time, and then we get to a point of whether we do ablation or whether we want to go with a minimally invasive procedure of doing a hysterectomy. Do you understand what a laparoscopic hysterectomy is? Okay, that's leaving the cervix behind. The reason they are so much less painful is because we don't go through a lot of those major structures that keep the uterus and everything intact, okay? Doing a laparoscopically assisted vaginal hysterectomy, just by virtue of having to go up through the vagina, we have to take the cervix and everything out, and we go through those stronger structures. So consequently, it's more painful. Recovery is at least a week longer, 4 to 7 days longer is what most studies show, and we've seen that when we've done it. The other thing is that, lest anyone think that all we do is laparoscopic hysterectomies, we go after it laparoscopically, but the vast majority of the hysterectomies that we've done over the last 6 weeks were laparoscopically assisted vaginal hysterectomies for that very reason, because of concern of cancer or possibility of that type of thing. So we do a different approach. So it's not all cookie cut it out. I mean, So there. Any other questions? Okay, I think we're ready for lunch. So. Thank you.